It's a perfect one. You're at Parker University. I love seeing like the tours that go around. They're like, never mind, I won't go there. All right.
He's on video.
All right. So what did people find? Give me, just shout out something that you found. Not all. What's up, man?
Left hemisphere.
Okay, well, give me more specific. What test did you guys do?
Okay, so we ran through this one and this one. I don't know what they call it.
What is that called? Okay, so that's called, we're going to call that a DDK.
DDKs, yeah.
What is that primarily checking out? Let's start super basic, guys. Okay, so I just drew this huge blue thing up here. Let's start out super simple for those of you guys that are new to the crew, right? So what's up here? Cortex, cool. So we'll say this is left, well, patient left, patient right? Okay, so we're going to call this the cortex. What does the cortex include? Frontal, parietal, occipital, temporal. Cool. All right, so basically the four things are right here. Frontal, parietal, temporal, occipital, right? Okay, and then we break it down. So if I took this, where does my little... I'm basically drawing... Where is it? There it goes.
The brain.
So if you took the brain and you flipped it upside down, you like chopped the spinal cord off and you flipped it, and we're looking at the bottom, that is going to be this, okay? I'm just not doing that because I want to make sure y'all know what all these are. All right. So what is this down here? Spinal cord, cool. That's the sideways on. All right, whatever. I'm going to confuse you guys. All right, what's right above the spinal cord? Medulla, yeah? What's right above the medulla? Pons. What's right above the pons? What's the difference between midbrain and mesencephalon?
None.
Cool. I have a lot of people ask me that. You know, I keep hearing mesencephalon, midbrain, whatever. I don't know why it is. They do this in the basal ganglion too. They give everything like two names. And it's super confusing. So anytime you hear midbrain, it's right above the pons. Anytime you guys hear mesencephalon, right above the pons. Okay, and then there's the hypothalamus and stuff, but we're not really worried about that functionally right now. So what's on the sides of the brainstem? Okay. All right, cool. So this gives you guys an idea of when we say like, okay, this test goes to here. This gives you an idea of like where we're talking about. Okay. So DDK, dysdiadochokinesia, right? Positive finding is if they start waving at you, or if one side's a little floppy, it's like your lucky fin finding Nemo. Okay. All right. So that's a cerebellar finding. So if it's on the left side's a positive finding, which cerebellum is deficient? If the left side's deficient,
Left side.
right, correct. Okay, cool. So what side would you adjust them on? If in a perfect world that was your only finding. Cool. All right. So DDK, check. What else? Somebody give me something else y'all did to figure out to do an analysis on somebody. Pincher test. Cool. And what does that test? That's kind of cerebellar too, but it's more cerebellar cortical axis. It's how well you can control that with the rate, the tempo, the amplitude of that. If it's small, if it's got hesitations in it, or whatever, you've got a cortical cerebellar axis, okay? So if you had your left pincher was bad, what side is the bad cerebellum? What side is the bad cortex?
Right.
Cool. Good stuff. What side would you adjust them on? So you guys are getting this. This is good. Good. Okay, what else do you guys do? Do you want to do gait?
Yep.
Right.
Is it fair to say that, like, the thalamus is going to be part of the mesencephalon? That's where most of your tracks are going to cross hemispheres.
I would say it was above that. So if we had the mesencephalon, then we'd have like the hypothalamus, thalamus. What you would normally see is that cerebellum would come over to, and we're going to talk about these tracks in a second. It would go to this pons, this mesencephalon, on the way to this thalamus and this cortex. So you want to have it stop here to control autonomics to help out with whatever movement you're doing, and then you want to go over the thalamus. It's just like the operator to the cortex. The thalamus is like your bouncer at the club. It like decides who's cool enough to go to like the top floor of the club, the VIP section. If you're not cool enough, like, he's like, we don't need to reach conscious awareness, you just chill. Like, you wait your turn kind of deal. Okay? And if something's important enough, like pain, or something's important enough, sensory, where it keeps just hounding the thalamus enough, the thalamus is like, okay, you can go. Does that make sense? Okay. So, someone give me another test.
Saccades.
Saccade. Okay, what's a saccade?
It's the eye movements going from one point to another.
Does it follow anything?
Follows the target, so you have a target.
I like to set you up for failure on that, my bad. Okay, so we got two kinds of eye movements, general eye movements. You've got a pursuit, where you're following a moving target, and the only time you can do a pursuit is if you're following a moving target. I can't pursue something that's not there. It's just a bunch of saccades, which is the second thing. A saccade is when you look from point A to point B, and it's a fast, direct eye movement to another thing, right? So what he's talking about is a saccade from A to B. So that's a frontal, okay, I'll give you that one, frontal lobe test. And a frontal lobe, if I saccade from the right to the left, so if I saccade to the left, it's a right frontal lobe axis. That's where my problem is, if it's bad, okay? So if I see a saccade that's bad, let's say if it's a bad saccade to the left, what lobe is it?
Your right frontal.
Right frontal, okay? And where would I adjust, left or right?
Left.
Good. Does everybody get that? Because anything I adjust on this side is going to this cortex. Okay? What's the other kind of saccade again? Or what's the other kind of eye movement again? And who knows what function of the brain?
Parietal lobe.
Good. So if I pursue something to the right, it's the opposite. It's ipsilateral cortex. So if I pursue something to the right, it's right parietal lobe. So if I look at somebody and they're pursuing something to the right and their eyes are like, you know, they're not smooth, and you'll see that a lot. You know, even in people in here, you'll see it. It's right parietal lobe. You would adjust them on the left side. See if you can bring that integration to the right cortex up. Okay? So now that we've got, that was good. So these are just some of the tests. We're going to expand on that today. Did anybody do gait?
Yeah.
Success or no?
Yes.
Pretty good?
Yeah.
Okay, so what would you guys look for in gait?
Arm swing.
Arm swing? So if you saw a decrease in arm swing on the left, what side would you adjust them on?
The left.
Left, yeah. Or which way could you spin them to give them a little vestibular input?
Right.
Ooh. You still spin them to the left. So I would want cerebellar input, yeah? So I would want vestibular input, vestibular nuclei on the left to go to the left cerebellum to go to right cortex. Okay? So that's gait. We're going to talk a lot about gait here in a couple weeks. It's kind of crapping out at me, sorry guys.
With gait, you can also check and see if a cortical activity makes it worse or better.
Yes, so dual tasking. And we're going to have a whole day on that too. So I just wanted to make sure that you guys are getting some of this stuff we've been doing so far, because today we're going to do this first and then we're going to expand on that. So basically, like as chiropractors, our main goal, oh yes, thank you. Just a black. Our main goal is to make sure that both hemispheres, so those four lobes in the cortex, on this side are firing as high as possible. And we're making sure that these four, so because you know you've got a frontal, parietal, occipital, temporal, right? So we make sure that all four of these are firing as high as they can. All four of these are firing as high as they can, and they're even. Right? That's huge. So if we have a decrease in any one of those and we start to see a seesaw effect, that's when we start to have really bad problems with health, whatever, and we will see controlled autonomics change and stuff like that. So by doing that, what's the main input to the cortex?
Proprioception.
Proprioception, but on here. So if I took out cortex, what in here fires to the cortex to keep that cortex firing really high? Cerebellum. Is the opposite or the same side cerebellum? So we're going to have this, and we're going to have that, right? So if I have a decreased left hemisphere or a left hemisphericity, I adjust them on the right. So we know that. So now we're going to add some stuff today. Now we're going to be talking about autonomics. So now we're going to be talking about cerebellum input into the same side pons, and the opposite mesencephalon or midbrain. So over here, same thing. This side pons, this side midbrain. Okay? So Does anybody have any questions before we start? That was kind of a rapid fire review round, but I think most of you guys have been here, so everybody get that okay? Okay, cool. All right, the brain. The Bears, because I'm from Atlanta and they just beat the crap out of the Falcons, so won't go there. So does everybody get, let's see, cover that. That just kind of gives you an idea of like where everything is. If you guys need to see like the pons and the midbrain's right above that, then the thalamus. The thalamus is just, you know, the bouncer on the way up. Okay, so no problems there. So the PMRF, or as Tyler likes to call it, the PMRF. We got 4 main functions that we're going to talk about, that we're going to introduce today, okay? And that's, what is the PMRF, first of all?
What does it stand for?
Let's start with that. Ponto, medullary, reticular formation, also known as the brainstem. So if we go right here, it's right here. So check this out. We've got, right when the spinal cord starts to come up into the brain, we've got the medulla, the pons, and the midbrain right here. We've got the mesencephalic reticular formation and the pontomedullary reticular formation. The main function, even before I get into this, the main function of this, who knows what the reticular activating system is? Because a lot about what we're going to talk about today is the cortex firing down, so we can do cool stuff, but the main one is this firing up to keep you conscious and alive. If this doesn't fire up, you're in a coma. Okay? So it'll affect some of the sleep-wake cycles and stuff like that, but if this pathway coming up to here is like cut off somehow, you're just laying in bed doing nothing, right? Okay, so now we're going to talk about these going down and affecting the pons and the medulla. So 4 main functions. So how much, is that my trimmer? Holy, all right. So 4 main functions that we care about as chiropractors for the pons and the medulla right now. So leaving out the mesencephalon. The first one is inhibition of pain. Last week we talked about out of all 100% of the cortex firing down, how much of that goes to the midbrain and the pons and the medulla? Does anybody remember? Huh? Okay, so we've got 100% of cortical output coming down, descending output. We've got some that goes to motor neurons, direct motor control. That's 10%. The rest of that 90 goes to right here. The mesencephalon, the pons, and medulla, and that's going to control autonomic function. Okay? So out of that, 90% of that goes to the pons and medulla. So 90% and 90%, that's 81% of brain function goes right here. That's why we care about it. That's a lot. So this can tell us a lot about the health of somebody, because that's 81% of cortical output, right? Okay, cool. So going back to the 4 main functions of this right here. I need to draw this before I do that. The cortex, because that's what I just said. They fire down ipsilaterally. So cortex fires down to the same side pons, same side medulla, same side mesencephalon, okay? The first one is inhibition of pain. If this doesn't fire, you guys hurt a lot. So you guys will have patients come in and they're just achy. And they like to get adjusted because it helps getting adjusted. So they're like, yeah, it hurt. And I'm like, okay, tell me where you hurt. And they're like, well, my left knee hurts. And come to think of it, my left elbow hurts. And kind of my left shoulder hurts too. I'm like, does anything hurt on the right? And they're like, that's weird, no. And I'm like, Okay. So that kind of gives you guys a heads up that maybe we're looking at a brainstem function that it's just not getting that bouncer, like is sick for the weekend, and you hired some like little skinny dude that's just letting everybody in, and you don't have a good gate on pain. Okay, so you've got, this isn't working. So if you have inhibition of pain and the PMRF is broken, you get pain. You get random pain. Okay? The next one is, actually I want to do, which one? Okay. This one's the next important because this goes with pain. So why are they hurting? What's the number one cause of pain orthopedically that we look at as chiropractors? Dysfunctional what? Okay, dysfunctional joint. I like that more specifically. So said really simply, it's bad mechanical loading of a joint. The muscles aren't working right to control the joint. The joint starts moving badly. The nerves that are in charge of letting the brain know about that joint start becoming sensitized. to where there's pain in the joint because the joint sucks. Make sense? So we've got pain in a joint because it's being mechanically loaded the wrong way. So here's the problem with that is one of the other jobs is the inhibition of a Renshaw cell. So you've got a motor neuron, here's the spinal cord. Whatever, right? Let's say this is a motor neuron. Every time a motor neuron fires, let's say I go to activate my bicep, I've got to have a Renshaw cell that as soon as I activate my bicep, it's got to inhibit that so that when I don't want to activate my bicep anymore, it'll relax. If that Renshaw cell's not there, it's going to go into tetanus every time I want to do something with my arm. Does that make sense? So the PMRF, what that does is it fires down from the brain to inhibit the inhibitory neuron. So you get normal muscle tone. You want that balance because you want normal muscle tone around a joint so that joint doesn't get messed up and you don't have pain in your joints, right? So if this is broken and you can't inhibit the inhibitory neuron, it actually gets weak. Does that make sense? Okay, so if you've got a weak muscle tone around a joint, you're going to have pain going back to this. So because you just don't fire down to that Renshaw cell, you have bad motor tone. Because you have bad motor tone, your joints hurt. Because your joints hurt, it causes pain, and because this is messed up, you can't block the pain, so now you hurt. That was a long way around. Everybody follow that? Okay, cool. So we've got motor output. Let's say these are going to the muscles that control the form around a joint, movement around a joint. This activates the muscle, yeah? Okay. There's this Renshaw cell that's right here. It's a neuron, it's an inner neuron that fires to inhibit that. So when I fire it, it'll release it when I'm done wanting to fire it. Okay? So I've got this that fires down right there to inhibit the inhibitory neuron to actually give you a little bit of tone when you need it. You don't ever want to fire a muscle just zero because you're not using it. You want to have normal muscle tone. So that's why this is here. So when this is broken, you see decreased movement or decreased muscle tone around a joint, which gives you bad mechanoreception and bad mechanical loading on a joint, which will cause pain, leading back to this when you can't inhibit the pain, so now you've got hurting joints. Okay? So people that go to MDs and people that go to all of these kind of doctors and PTs or whatever, and they say, okay, I got fibromyalgia. I've got everything that's hurting. You know, it can be a bunch of different things, but they don't look for this kind of stuff. Maybe you just need an adjustment. Maybe we just need to activate that brainstem a little bit, then you won't hurt. It'll be fine. When was the last time you've moved? When was the last time you've exercised? And they're like, I don't know. When was the last time you got adjusted? I don't know. When was the last time you had a salad? I don't know. And then you start talking to them, and then you're like, oh, wow, that's cool. And the patient likes you and comes back because all the other doctors they went to didn't ask him those questions. And this is kind of, come on. Sorry, guys, hang on. I know it probably is. That was stupid of me, my bad, guys. That's okay. So here's my next thing. Before, I don't need a picture for this. So now I've talked about that. All right, now we're getting into autonomics. So now we've talked about that. Give me some autonomics. Like if a patient came into your office in a chiropractic clinic and was complaining of autonomic dysfunction, shout out some stuff that you would see. Sweating, cool. What kind of sweating? Be more specific. Could it be on both sides?
Could be, yeah.
Could it be on one side at a time?
Could be.
This isn't cool. So just abnormal sweating. I like that. What else?
Pupil size.
Pupil size. What about pupil size?
Jason, what's the question again?
Just name autonomic dysfunction. Patient comes in with blank. You know that it's autonomic dysfunction.
Cold hands and feet.
Cold hands and feet. So temperature?
Constipation. Orthostat.
Heart rate.
Somebody say constipation? People.
Positional errors.
So let's talk about pupils for a second. This is normally a dead giveaway of autonomic dysfunction right here, because you can look at somebody's eyes and you can tell a lot about their autonomics, right? Does anybody know what this is called?
Yes.
Huh? Alright, anisocoria. So, coria. That means, all that means is one pupil is a different size than the other pupil. So what makes a pupil big? Is it parasympathetic or sympathetic input? Sympathetic, yeah? So it could be two things, actually. Sympathetic could be up, or parasympathetic on this side could be down. And then if this one's small, you've got two options, right? So what makes it small? Increased parasympathetic. Or decreased sympathetic. Now, we talk a lot about this, but I gotta stop for a second, because clinically, let's say it's not an emergency, right? Nothing happened to cause this, they just came in over time, it's a chronic lifestyle that's causing this, right? We're gonna look at autonomics. Let's say, who wants kids again in here? Who's talking about doing sports med or sport injuries or athletics in general? Let's say you guys have a kid, or let's say you guys are a doctor at a game, and there's a kid that goes head first, you know, it's a head first tackle, or he gets a puck to the face, or he runs head first into whatever, and he goes down, right? And all the parents look at you and they're like, oh, you're the doctor, like go check him out. Okay, and you're like, all right, cool. So you go look at him. And they open their eyes, you can do an impact test, you can do a field assessment for a concussion, you can do whatever you want, but you notice that one pupil's bigger. So other than sympathetic input, what could a big pupil mean? Give me time to think about it for a second. Hang on. It normally means pressure. Pressure of something in the cranium is pressing down on that mesencephalon, or that midbrain, and that midbrain is that sympathetic part that dilates the eye. So, pressure. What could cause pressure in somebody's head?
Fluid.
Ooh, fluid. What kind of fluid? Cerebrospinal. Give me something else. Blood. That means they got bleeding in their brain, and that's a call to the ER, that's a call to the ambulance that you're done. That's an ER situation. So before I say anything else, that kind of scenario isn't something where like, yeah, let's check out their autonomics and try to balance it out with an adjustment, right? That's like, no, you're bleeding. We need to make sure you're not bleeding. And if it is, we need to make sure that that's taken care of right away. We're calling an ambulance for you. Cool? So there's your price of admission right there. Don't try to like play with them and try to do some eye stuff, and you know what I mean? That's like, okay, this is a for real injury. We're done, right? Me and Spencer were watching a game this past weekend where the kid, it was a soccer game, and the keeper came out, he went head in to this dude, and one of the telltale signs of a concussion is if they lay there and their hands kind of go up reflexively to protect their head and they're just kind of out of it. That's your concussion sign right there, positive concussion. That's TBI. And he kept playing for like 13 minutes. Like the field doctors went out, assessed him, and they were like, he's fine. 13 minutes, his ear starts bleeding. Or his ear's not, but he's got bleeding coming out of his ear, and that's when they stopped the game. They're like, okay, maybe this is kind of for real. Like, you know what I mean? It shouldn't take that. So if you see hands go up, it happened to Tebow a couple years ago too, when he was playing at Florida, and he got whacked. He was like trying to go into the end zone. He got drilled by like two linebackers, and his hands went up, you know, and the sports med guys came out, and they're like, he's cool. And like the next play, like he forgot the play. And they were like in his earpiece, like what's going on? And that's like, okay, you know, we're done. So it shouldn't take that. As a doctor, you should be like, okay, let's be smart. You know what I mean? Like something's going on, we need to take you out of the game. So back to this, anascoria. So that's cool. So we know that's probably sympathetic, this is probably parasympathetic, or this is probably lack of parasympathetic, or this is probably lack of sympathetic. I feel like we covered most of that stuff. Oh, also, so we also talked about this last week too. So if you guys go in and you want to do an orthopedic evaluation as a chiropractor and you say, okay, their shoulder's internally rotated, that's cool. You adjust the external rotators and you bring it back. You adjust the posterior muscles, or you fast stretch the anterior muscles and you bring it back. Right? But then you got to look at the foot, because a PMRF lesion would give you this. So it's going to give you internal rotation of the arms, external rotation of the legs, and then you're not just dealing with a shoulder. Right? So if this gives you internal rotation, your scapula wings out, the muscles attached to the scapula to the spine will move, and you've got thoracic subluxation that way, and you're sitting there trying to nail all their thoracics and they keep coming back, and it's not a thoracic thing. So just check, right? It's pretty easy. You can count knuckles. So if they're like this, let's say this side's normal, and this side's the one that's messed up. If Bryce is standing there right in front of me, and this is normal, and I've got this hand is internally rotated, or you can sometimes see an elbow flexion thing. So if he's counting like 4 of my knuckles on this hand, and like 1.5 knuckles on this hand, that's a really quick way to be like, hey, the shoulder is internally rotated. Cool? That's like without even touching them. And if they sit there and they close their eyes and they move their head up and down and they do this like 10 times or whatever, and they land and that foot's kind of out, and you're like, maybe that's externally rotated, and then you can do a muscle test to find out. Sometimes it's just the way they step. You know? A really quick way too is to look at people's shoes and figure out where they wear down. Because if they wore down on the outside or the inside, it can tell you a lot. That's why you probably shouldn't wear other people's shoes, because you can give each other your subluxation. Think about it. So, talked about pain, talked about, inhibition of IML. Do you remember what IML stands for from last week? I know, that was a hard one. I'll give somebody a shirt if they can remember that hasn't been here last try. Anybody? 3, 2. Intermedial lateral cell column. That's the part in your spinal cord that controls your sympathetics. So if I say IML, it activates sympathetics, okay?
Hey, Jason.
Hey.
I want to say, too, we were talking about autonomic failure.
Yeah.
The first cardinal sign is going to be like an orthostatic type of failure. So you're checking blood pressure supine versus like standing up. That's the cardinal signs of the first cardinal sign of autonomic dysregulation.
So let's say this cerebellum right here. Actually, let's say both of them. Let's say this cerebellum fires into this side pons and this side medulla to control autonomics on this side. This right cerebellum fires into this side pons and this side mesencephalon, or this side midbrain. Because if I stand up, these cerebellum go, hey, we're moving, we should probably get some blood down there. Right? Or the parts in our brain that are controlling the movement need some blood up there. So we should probably send blood to the places that are actually working right now. And if these places right here crap out, they don't do that. So you get blood pooling in places where you shouldn't have blood pooling, and their heart rate changes, their blood pressure changes, they can pass out, they get POTS, they get all these different kinds of things. Because of that, the cerebellum goes, hey, no, for real, we're moving. Blood would be good, oxygen would be great, and they're like, we can't do it, we're not well. So they don't fire. When they don't fire, you can get stuff like that. That's huge. So ask them, when you take blood pressure, it's not enough to do blood pressure lying down. You have to do it seated, you can do it standing up, because a lot of that stuff will change if you put a pulse ox on them and just get them to stand up. Do a squat and it jumps like 30 points. You're like, whoa. They're like, yeah, I always felt lightheaded when I stood up. I thought that was like kind of normal. You know? So, anyway, so we talked about that. By saying inhibition of anterior muscles and posterior muscles below T6, that's just the point where it flip-flops. That's like when your nervous system is like developing. That's the part, I don't know why, but that's the part where you see internal and external rotation. So it gives you a lot of flexion, anterior flexion and posterior, a lot of that, like hip extension, knee flexion, stuff like that. So we talked about that. Okay, so this is y'all's turn, because these are the tests that we're going to do. So everybody partner up.